Welcome, everyone. It's my pleasure to invite all of you to the 10th Annual New Horizons in Neuroscience Symposium. My topic today is Neurostimulation Therapies in Neurology. All of my current conflicts of interest have been disclosed and are available for review in the Covenant CME office. In the next hour, I'll be discussing some commercial products out of necessity for the purpose of this lecture. The logos on the products have been blocked to prevent the appearance of any conflict of interest. Some items have not been blocked, only to highlight their historical context and should not be construed as an endorsement of any of those. I also want to disclose that I was a principal investigator for two of the products that will be discussed today. Those are the deep brain stimulator for epilepsy by Medtronic Corporation and the vagus nerve stimulator for the treatment of epilepsy by Cyberonics Corporation. Medicine has had four modes of therapy from time immemorial. They are talk therapy or counseling, the use of medications, physical therapy in the form of massage and exercises, and surgical therapy. Today, neuromodulation with computer interface is fast becoming a fifth dimension in the therapeutic armamentarium available to the practitioners of the healing arts. According to the International Neuromodulation Society, there were 66 neuromodulation devices on the world market as of a review done in 2014. These include implanted pulse generators or IPGs, and the minimally invasive electrodes that stimulate the cerebral cortex, the deep brain nuclei, cranial nerves, spinal cord, dorsal root ganglia, and some of the cranial and peripheral nerves. The targets for stimulation include the subthalamic nucleus, globus pallidus internus, and the pedunculopontine nucleus for Parkinson's disease, and the various other nuclei that are listed on the screen, some of which I will discuss in more detail as we move along. The MRI scans on the screen show some of the points of interest that I mentioned and some others that are in experimental use for various conditions. Pictured on the screen are the images of Penfield and Jasper, who work together at the Montreal Neurological Institute, which is on your right-hand side. These men worked together for several years as partners and may be considered the pioneers of modern neurostimulation. Penfield, who is standing, was the director of the Montreal Neurological Institute, and Jasper, who is sitting, was his electroencephalographer. What you see on the screen is a picture that most, if not all of you, are familiar with and resulted from their experiments in neurostimulation in patients on whom they performed stimulation experiments during their brain surgeries, at which time the patients were kept awake for cortical functional localization purposes. The efforts of stimulation of the various parts of the cerebral cortex in their patients is what led to the creation of the picture of the motor and sensory homunculi that you're looking at on the screen. Picture on the left on the screen with me is Dr. Herman Flanagan, who is the professor of neurosurgery at the Medical College of Georgia in Augusta, Georgia, where I did my fellowship in EEG epilepsy and evoked potentials. Herman received his training in neurostimulation from Penfield, and he in turn trained me in the art of neurostimulation. On the screen is a picture which appeared in the article in the New York Times on May 17, 1965. The man in the picture is Dr. Jose Delgado. This is a picture of a demonstration of his ability to control the behavior of a charging bull using an implanted neurostimulator with a controller, which you can see in his left hand. In his right hand, he is holding the red rag for enraging the bull. Dr. Delgado was born in Spain and was interested in pursuing a career in ophthalmology, following in the footsteps of his father. However, as a medical student, he decided to serve in the Spanish Civil War, and after the war, finished his medical education and became interested in brain function. Because he was influenced by Dr. Cajal, who along with Dr. Golgi was responsible for developing the silver chrome stain with which the two were able to demonstrate the neurons of the brain, and for which they received the Nobel Prize in 1906. He then applied for a fellowship in Yale and later remained there as a professor and conducted his neurostimulation experiments. In the short video, you can see a bull being implanted with an electrode in its brain. After recovery, Dr. Delgado could still enrage the bull with a red rag as usual, but then was able to stop it in its track by using a transceiver. You can see that the bull turns away as he presses a button on the device in his left hand, which he called a stimoceiver. The first recorded use of electrical stimulation for a medical use goes back to Scribonius Largus of Mesopotamia, who in AD 46 used the electric ray for relieving headaches. He attached the electric ray to the skin of his patients for relieving their headaches. He also had some of his patients dip their hands in a bowl full of electric eels for the treatment of their headaches. The modern era of neurostimulation for the treatment of pain started in 1989 with the approval of the spinal cord stimulator for chronic pain from nerve damage. Following this, several devices were approved by the FDA, and new devices are still being approved. You can see a short list of these devices on the screen. I'll discuss only a few of these today. I'll start with stimulation therapy for chronic pain. For that purpose, let us start with the physiology of pain perception. We know that sensations enter the spinal cord via the dorsal root, and that pain sensations are carried by the slowly conducting C fibers. The large and fast conducting A beta fibers transmit non-pain sensations. This was considered to be a hardwired system wherein sensations entered through the dorsal columns and were passed cephalad, and the motor impulses were carried by the fibers exiting through the ventral division, allowing for reflex and voluntary activities. This concept and our understanding of transmission of signals changed dramatically with the proposal of the gate theory by Melzack and Wall in 1965. Their theory met with a lot of criticisms in their time. Nonetheless, their work revealed the complexity of the mechanisms of pain perception, and the gate theory nowadays is generally accepted. The diagram on the screen explains the process. In the scheme proposed by Melzack and Wall, when the C fibers carry a pain signal into the substantia gelatinosa orlando, it sends an inhibitory signal to an interneuron, which normally inhibits the projection neuron. Such inhibition of the inhibitory interneuron releases the projection neuron from inhibiting the signal carried by the C fibers and allows its passage to the higher levels of the nervous system for processing. Thus, the C fiber enables the passage of its signal forward by using this inhibitory interneuron. It is by this means that the C fiber enables the passage of its own signal by opening its own gate, so to speak. To the right hand of the screen, you can see how a signal arriving at the same time through a large A beta fiber can modify the behavior of the projection neuron through which the pain signal has to pass. Here the A beta fiber sends a twig which behaves as an agonist to the interneuron, which when stimulated increases the inhibitory influence of the interneuron on the projection neuron, thereby closing the gate and preventing the passage of the pain signal arriving at the projection neuron through the C fiber. This is what came to be known as the gate theory, named after Drs. Melzack and Wall. 2 years after the theory was proposed by them, the first clinical application of the theory was reported. In 1967, a neurostimulation paradigm was designed in which an electrical signal was sent to the dorsal column, where the large fibers are, through an epidurally implanted electrode with an impulse generator. After 22 years of painstaking research, the FDA approved the first device in 1989, marking a new era in the neurostimulation therapy for pain and for neurostimulation treatments in general. I do not intend to detail the long and painstaking process of research in those 22 years and the various failures the researchers faced, including deaths as they try to perfect this therapeutic modality for the treatment of their patients. I will only be discussing the process as it is practiced today. The picture shows the placement of electrodes in the epidural space. After a temporary placement for 2 to 4 weeks, during which the IPG is secured externally to assess the patient's response, it's implanted subcutaneously if the patient's response is positive. Let us now take a look at the outcome of this therapy. Instead of doing an exhaustive review of the research behind its approval, let me share with you one of the more recent studies from 2020 that looked at the efficacy of the epidural stimulation therapy for pain in the current state of the art. The one I'm going to discuss today was published in Neurosurgery in 2020. Although earlier studies were done using low-frequency stimulation, this particular study used a 10 kHz signal for the purpose of stimulation, which eliminated the menacing paresthesias and limb jerks associated with the low-frequency signals used earlier. This was a prospective single-arm multicenter trial with a 3-month period of enrollment and 12 months of follow-up. 100 patients were enrolled, 55 qualified, and 40 people completed the trial. 3 different measures were used to evaluate the device's efficacy. They were the 3-point pain and sleep questionnaire, the mean PQSI score, and subject satisfaction. Let us first look at the results of the 3-point pain and sleep questionnaire. The first of the 3 points in this questionnaire was how much trouble you have falling asleep due to pain. As you can see, over the course of the 3, 6, and 12-month evaluations, the scores improved from 6.3 to 2.2, indicating that the interference with the sleep by the pain sensation was significantly reduced. The second question was how often are you awakened by pain at night? The middle section of the graph shows the score, which improved from 6.8 to 1.9 in those who received stimulation therapy. Third question was how often are you awakened by pain in the morning? Here too, the scores improved from 6.8 to 2.0. Now let us look at the results of the mean PQSI score. PQSI stands for the Pittsburgh Quality of Sleep Index, where a lower score indicated improvement in pain. As you can see, 2/3 of the patients were women with a mean age of 55.8 years and an average duration of pain of 11.4 years. The percentage of improvement was 33.8 by 12 months, as represented by the blue bars. The PQSI score improved from 12.5 to 8.3 by 12 months. The third measure used in the study was subject satisfaction. It goes without saying that this is the ultimate measure of success for the procedure. Remember, this was a group of patients, all of whom had chronic intractable neck pain, with about half of them having upper limb pain as well, from radiculopathy or degenerative disc disease. Close to 56% of the patients had failed C-spine surgery syndrome. The patient satisfaction from the procedure was 88.9% at 3 months and 95% at 12 months. It is interesting to note that although 8.9% were not sure about its benefit at 3 months, that number shrunk to 2.5 at 12 months. Very impressive indeed. Soon, the FDA approved dorsal root ganglion stimulation for complex regional pain syndrome, and that occurred in 2016, followed by spinal cord stimulation for back pain and leg pain from all causes, which occurred in 2018. Lastly, spinal cord stimulation for diabetic peripheral neuropathy was approved this year in 2021. As we have already discussed spinal cord stimulation for various painful conditions, let me say a few words about dorsal root ganglion stimulation for chronic regional pain syndrome. St. Jude was the first one to get a nod from the FDA for its IPG for dorsal root ganglion stimulation. Their device is what is pictured here in its historical context. The diagram shows the placement of the electrode over the dorsal root ganglion. The procedure is done under local anesthesia. Initially, the IPG is attached externally for 2 to 4 weeks, after which the device is implanted subcutaneously if it leads to patient's improvement. Now let us look at the rationale behind its approval. This slide shows the data submitted to the FDA by the manufacturer. The green line shows the patients who were in the Axiom protocol, as it was called, and the interrupted blue line shows the control group who continued to receive their treatment in the form of transcutaneous nerve stimulation. At the beginning, some reduction in pain was seen in both groups during the first month, but as the Axiom group began receiving dorsal root ganglion stimulation, there was a clear separation in the response rate of the two groups. Note that the control group continued to deteriorate in terms of their pain. Pictured on the screen is the first device called Omnia by Nevro that was approved for diabetic neuropathy, which happened this year, as I mentioned before. Several improvements have taken place over the years, both in miniaturization of the impulse generator as well as in the design of the electrodes, as you can see in the pictures on the screen. What you're looking at is a miniature spinal cord stimulator and a specialized multi-electrode array for electrodes that can be implanted in the epidural space. This slide shows the multiplicity of currently available devices with various functional improvements. The next condition I would like to discuss, for which the FDA has approved neurostimulation procedure, is deep brain stimulation for Parkinson's disease. That was the first condition for which deep brain stimulation was approved by the FDA. Parkinson's disease was first described by James Parkinson in 1817. The cardinal features of the disease were described by him as tremor, rigidity, and bradykinesia. Later, postural instability was recognized as an important clinical feature of the disease. It is very interesting to note that the first three clinical signs described by Dr. Parkinson are the only ones that are responsive to neurostimulation and not the postural instability that was added later. The pathophysiology of Parkinson's disease is deep pigmentation and degeneration of the substantia nigra compacta in the brainstem. The depigmentation is the result of decreased synthesis of dopamine in the substantia nigra, which leads to decreased transport of dopamine by the nigrostriatal projection to the basal ganglia. On the screen, you can see an example of the normal substantia nigra on the top and the dopamine depleted substantia nigra below it. When the dopamine levels in the basal ganglia decrease because of decreased transport from the substantia nigra, it results in overactivity of the striatal neurons because of the absence of the inhibitory effect provided by the dopamine. This phenomenon can be demonstrated by a SPECT scan using a cocaine analog tagged with I-123 with the US trade name DATscan. What you're looking at the screen is a dopamine transport, or DATscan as it is called, which was approved by the FDA in 2001. Ioflupane I-123 binds to the dopamine transport protein. The image shows a reduction in the protein and consequently decreased ioflupane I-123 uptake in the corpus striatum on the right compared to the left. It is important to note that this is a demonstration of the dopamine transport system and is not a diagnostic test for Parkinson's disease. Its FDA-approved indication is the differentiation between Parkinson's disease and essential tremor. This diagram shows the nigrostriatal pathway and the influence of various neurotransmitters on the nigrostriatal system as it relates to the pathophysiology of Parkinson's disease. Dopamine is inhibitory to the striatal neuron, and in its absence, the excitation of the striatal neurons by acetylcholine and glutamine is what causes the clinical symptoms of Parkinson's disease. The initial approach to treating Parkinson's disease in the 1950s was the use of anticholinergics to reverse the excess activity of acetylcholine to balance the function of the striatal neuron. Later in 1973, the antiviral amantadine, which reduces the glutamatergic activity, was approved by FDA for its treatment. Dopamine does not cross the blood-brain barrier, and so L-DOPA, which crosses the blood-brain barrier, was introduced as a treatment in the 1960s to boost the synthesis of dopamine in the neurons of the substantia nigra. Monoamine B oxidase inhibitors and catechol-O-methyl transferase inhibitors also are effective as they work by inhibiting the synaptic catabolism of dopamine, thereby increasing the level of the available neurotransmitter in the synapse. Although the initial medical treatments in the 1950s were somewhat effective, the progression of Parkinson's disease continued, and therefore surgical treatments which were developed in the 1950s remained a viable option for patients with Parkinson's disease. Dr. Irving Cooper was a pioneer in surgery for Parkinson's disease. While performing a mesencephalic pedunculotomy in 1952, Dr. Cooper accidentally injured the anterior choroidal artery in an elderly patient. This unexpected event made him ligate the artery and close the wound without performing the pedunculotomy. He waited in agony, as such a procedure was bound to result in an infarction and contralateral hemiparesis. Lo and behold, when the patient woke up, she did not have any neurological deficit and the tremor was gone. After this accident, Dr. Cooper went on to perform such surgeries on 50 more patients with Parkinson's disease. This serendipitous event and the lackluster results of medical therapies in the 1950s resulted in further enthusiasm on the part of neurosurgeons to perform lesional surgeries in the areas where Dr. Cooper's mistake caused a tiny lesion in the striatum and not the massive stroke he expected. Initially, these surgeries were done after large craniotomies, and because of the morbidity associated with large craniotomies, several people were working on stereotactic frames. On the screen is a picture of a drawing for such a frame by Dr. Leskell in 1949. This enabled surgeons to place precise lesions in various deep brain nuclei through burr holes made in the skull, and surgery to treat Parkinson's disease became popular again. The lesions were produced in the ventral intermediate nucleus, which primarily reduced the tremor, and it is still used for the alleviation of essential tremors. Destruction of the globus pallidus internus reduced the tremor, rigidity, and bradykinesia, the classical signs of Parkinson's disease, and similar results were obtained by destroying the subthalamic nucleus as well. In 1960, a Japanese neurologist, Isamu Saino, first suggested levodopa for the treatment of Parkinson's disease. Although the initial results were not favorable, later work by others made this one of the most remarkable achievements in medicine in the 20th century. Surgical ablations for Parkinson's disease fell in disfavor as a result of the success of levodopa-carbidopa combination therapy in the 1960s. However, after an average of 5 years of therapy, those patients also began to develop problems, particularly the so-called on-off phenomena associated with treatment. Further, some patients also were noted to develop dyskinesias on the other end of the spectrum. These developments resulted in a resurgence in the enthusiasm for surgical therapy among neurosurgeons. As you can see from the diagram on the screen, in a 24-hour day, the patients with Parkinson's had fairly good response early on in the treatment of their condition with levodopa and carbidopa. But after a while, the amount of time they stayed in the effective range started to decrease, and in the off times, the patient became rigid. This is what is referred to as the on-off effect. At other times, they also suffered from dyskinesias, from overstimulation of the striatal neurons. The improvements in stereotactic frames and the potential to use other forms of creating lesions, such as radiofrequency lysis with precise localization to various nuclei that could be targeted with such frames, lesional surgery made a comeback. In addition to the precision afforded by the stereotactic frames, neurosurgeons found that the use of intraoperative recordings helped in targeting the various nuclei as well. As you can see from the diagram on the screen, the pattern of electrical discharges from the thalamus were different from those from the substantia nigra and the subthalamic nucleus, so much so the placement of these lesions could be made with better accuracy with the help of intraoperative recordings. Then came another serendipitous historic event in the evolution of the treatment of Parkinson's disease. To more accurately target the lesional sites while operating on a patient with Parkinson's disease in 1987, with the help of intraoperative recordings, Dr. Benabid, a French neurosurgeon, decided to stimulate the targets during the procedure. This was done because there have been efforts to treat Parkinson's disease by neurostimulation in the past, the benefits having been less than optimal. Dr. Benabid first used the 50 Hz frequency for stimulation, as was done in the past, and did not see any significant benefit to his patients. However, when he increased the stimulus frequency to 100 Hz, the patient's tremors stopped entirely. Remember, this was possible because it was typical for the patients to be awakened during surgery in those days for checking their improvement or lack thereof during surgery. Thus it became the next eureka moment in the history of Parkinson's disease after Dr. Cooper's discovery of the effect of creating a lesion in the basal ganglia for the treatment of Parkinson's disease because of the accidental injury to the anterior choroidal artery, as I discussed before. Dr. Benabid then continued to work in collaboration with Medtronic Corporation, and after 9 years of research, the European Union approved deep brain stimulation for Parkinson's disease in 1996. What you see on the screen is the first IPG produced by Medtronic for DBS for Parkinson's disease. It was called Soletra. Again, I want to emphasize that the picture is being shown only in its historical context and not as an endorsement of the product. Subsequently, the Activa Therapeutic System of Medtronic received initial approval by the US FDA for Parkinson's disease and for essential tremor in 1997, followed by full approval in 2002. The problems associated with the use of Soletra was that the IPG had to be implanted bilaterally to stimulate both basal ganglia. Surgery for the purpose was done in stages. The first step was the planning, followed by lead implantation and placement of the electrode under anesthesia, followed by awakening the patient to verify the lead placement, and then securing of the lead. In stage 2, the lead is run subcutaneously to the device, followed by stimulation to check the system with the patient awakened again. Finally, the lead is connected to the IPG and the wound is closed. Next, I would like to show a video to demonstrate what the patients had to go through in their day in their off stages and as they developed dyskinesias. The video also shows the effectiveness of DBS. Here is an example of a patient who has been off his medication for 12 hours, and you can see the extent of the tremors that he has. The next patient in this video is suffering from significant dyskinesias while on medication. This video is of a different patient before and after DBS is turned on. On your left, the patient is seen with his device turned off, and on the right you can appreciate the dramatic reduction in the same patient's tremors once the device is turned on. The images on the screen showed 3 different targets for stimulation. The ventral intermediate nucleus of the thalamus is targeted for essential tremor. The subthalamic nucleus and the globus pallidus internus and the substantia nigra are targeted for Parkinson's disease. The data are not clear as to which target is best for Parkinson's disease. The subthalamic nucleus does seem to afford more medication reduction after surgery, whereas the globus pallidus internus may be slightly safer from the standpoint of language and cognition. Now, let us take a look at how effective the procedure is. This slide is from a study published in 2009. It's a rather busy slide, But let me bring your attention to the best medical therapy versus deep brain stimulation 6 months after randomization of the patients. Here in the oval, you can see the patient's time without troublesome dyskinesias at 6 months as opposed to with troublesome dyskinesias above and below. These are the numbers for those who received the best medical therapy. On the right hand side, you see the time without troublesome dyskinesia and time with troublesome dyskinesia in patients who received deep brain stimulation within the same time frame of 6 months after randomization. The patients who had deep brain stimulation had a 3.8 or almost 4 more hours in the day without troublesome dyskinesias. That's a 50% increase in their time without dyskinesias. Similarly, the time with dyskinesias decreased from 3.9 to 1.8 hours, again representing a 50% reduction in their time with dyskinesias. 6 months after implantation, these results look impressive. But what happens to these patients in the long term? For that, let us look at a study published in Neurology in July of this year. In the study, there were 51 patients who were followed for 17.06 plus or minus 2.18 years after DBS implantation in their subthalamic nuclei. 15 years on the average after implantation, you can see that there was improvement in every measure evaluated in these patients. The time spent with the dyskinesias decreased by 75%. The off time decreased by 58.7%, and dopaminergic drug reduction was possible in 50.6%. There were improvements in the quality of life, emotional function, and social function as well, although the improvements were more modest in those 3 parameters. The next slide illustrates the fact that the disease progresses even in these patients, and that what DBS does is to simply reduce the time they spend experiencing off times and dyskinesias within the day. In the earlier days of stimulation therapy, the IPG used was the Soletra, which had a single lead or single electrode, which required bilateral implantation of the device for bilateral deep brain stimulation. This changed with the approval of the Kinetra, which had the capability to do bilateral stimulation with a single IPG. Kinetra was approved in 2004 with 3 indications, those being Parkinson's disease, essential tremor, and experimental use in obsessive compulsive disorder. This slide showed a comparison between the features of Soletra and Kinetra. Besides some of the technical aspects of programming, such as the gradual increase and smoother transition of amplitude of the signal, it reduced the number of incisions required because of the availability of 2 electrodes for stimulation. It has additional benefits such as the option for automatic shut-off at night and greater battery longevity, although it was available only following a certain period of time after implantation. In addition to Medtronic, there were other players in the field, as Abbott, St. Jude, and Boston Scientific in the business of making IPGs. They too began manufacturing the IPGs and electrodes, and competition proved to be good for innovation. You can see one aspect of that on this slide, namely the incorporation of smart devices for programming and the introduction of directional leads for precise excitation of the concerned nuclei. These improvements gave physicians the ability to direct the spread of stimulation in one direction or another around the electrode itself with wireless programming capabilities. In 2016, Abbott received the first approval for their DBS device with directional leads for the treatment of Parkinson's disease and essential tremor. The directional leads act very much like the sprinkler system for your lawn, where one has the ability to target the area covered by the spray from the sprinkler head by turning a knob on the sprinkler head to cover given quadrants around it. This is demonstrated in the blue bar on top of the diagram. Other companies such as St. Jude developed their own innovations, but St. Jude was later bought out by Abbott. Another manufacturer was Boston Scientific, which got its own patent awarded for their own directional leads and stimulation systems. Their Versailles system was approved in 2017. Not to be left behind, Medtronic, which was the pioneer in the field, came up with the Activa RC Sensite system, as is shown on the screen. Another innovation from Medtronic was in their IPGs called the Percept system, which had the ability to record the electrical activity of the implanted nuclei. Now let us take a look at how these things work to alleviate the symptoms of Parkinson's disease. The fact of the matter is that no one really knows the mechanism of action of these devices. The general consensus is that stimulation of specific nuclei in the brain alters the balance of inhibition and excitation by enhancing or inhibiting the effect of the specific neurotransmitters on the corresponding nuclei. The next device I would like to talk about is the vagus nerve stimulator. On the screen, I have purposefully misspelled the name of the IPG because many people use the term vagal nerve stimulator for the device. That is incorrect. The correct terminology is vagus nerve stimulator. Please remember that. Let me first say a few words about its background. From the 1930s onward, investigators have known that stimulation of the vagus nerve had various effects on the EEG in cats, such as producing fast activity in the orbitofrontal cortex, blocking of interictal spikes, and desynchronization or synchronization of EEG in the thalamus and the cerebral cortex. This slide shows the interruption of ongoing seizure discharges in an animal model by stimulation of the vagus nerve. On the bottom, you can see the ongoing seizure discharge recorded from the animal's cortex, which was interrupted by stimulation of the vagus nerve, as is shown in the top tracing. The first systematic studies in experimental animal models for epilepsy were done by Dr. Zabara of Temple University in 1985, followed by the first human implantation in 1988 by Drs. Kiffin Pentry, B.J. Wilder, and Gene Ramsey. Within 6 years, the device gained European Community approval in 1994, and after they completed a controlled clinical trial on 451 patients, the Texas-based Cyberonics Corporation was granted approval for its use in the treatment of epilepsy by the FDA in 1997. When implanting the VNS, the electrode is attached to the vagus nerve after it's exposed, as it lies next to the carotid sheath, as indicated by the red arrow in this diagram. Its cable is then tunneled toward the IPG, which is implanted in the chest, and then the two are connected to each other. The procedure results in a couple of scars, one on the neck and another on the chest. Those who want to hide the scar in the chest may do so by choosing to have the incision in the posterior wall of the anterior axillary fold. Now let us take a look at the 5 studies that I mentioned that led to the approval of VNS in the US. Those studies were designated EO1 through EO5. The first 2 were single-blind pilot studies and had 16 patients. EO3 was a larger study with 115 patients, and it was a randomized, double-blind, active control trial. EO4 was a compassionate protocol, and EO5 was the largest of the 5 with 199 patients, with a randomized, double-blind, active control protocol, and was completed in 1986. On the screen, you can see the results of these studies that led to its FDA approval in the US in the year following the conclusion of the studies in 1996. The colored bars represent the responder rates, which is the percentage of patients with 50% or more reduction in their seizures from baseline. The blue bar shows the responder rate at 3 months at 23%. At 1 year, it improved to 37%, and by 2 years to 43%. What's interesting is that the device maintained its effectiveness steadily even after 2 years of progressive improvement in its effectiveness. At the time of the initial approval, VNS was indicated for use as adjunctive therapy in reducing the frequency of seizures in adults and adolescents over 12 years of age with partial onset seizures, which were refractory to anti-epileptic medications. The surgical complications included infection, which in some cases led to explantation of the device, temporary vocal cord paralysis with hoarseness of voice, hyperesthesia of the lower half of the face, and paralysis of the lower face. There was one case of cardiac asystole after 10,000 implantations with a 0% mortality. The non-surgical side effects were related to the time when the stimulator was on, and these side effects lessened over time. These on-time side effects were similar across all age groups and could be managed by adjustment of the stimulus parameters for the most part as well. The original company Cyberonics maintained a registry for the implanted patients, and that made it possible to follow the effectiveness and side effects that the patients had over time. This slide shows the results of analysis of the data from the registry in 2000 in comparison to the original study. The first set of bars show the median percent reduction in the number of seizures. In it, the yellow bar represents the results of the pivotal studies, and the red bar shows the results from the 3 months follow-up of patients in the registry. The blue bar shows the results after 12 months. The second set of bars show the responder rates. The third set of bars show more than 75% reduction in their seizures, and the fourth set shows those who had more than 90% reduction in their seizure frequency. These results were much better than what was seen in the pivotal studies. An important point to remember from these studies is the fact that 19% of the patients in the registry had better than 90% reduction in their seizures at the end of the 12-month period. As mentioned before, the device-related side effects included hoarseness, cough, paresthesias in the lower part of the face, and dyspnea. All these steadily decreased over the 3-year period of follow-up in the VNS registry. This slide shows the robustness of the effect of VNS stimulation over time. This is a 3-year study published in 2017 with 90% follow-up, again showing sustained improvement over time at a higher rate than what the initial publication from the year 2000 showed. The study of 362 patients who were followed over 36 months showed that the device showed sustained efficacy with median seizure reduction at 41, 53, 60, and 66%, respectively at 6, 12, 26, and 36 months. Once implanted, the device can be programmed using a magnetic wand, which enables the physician to make adjustments in stimulus parameters to modify the on-time side effects and to improve seizure control using the equipment and training provided by the manufacturer. Now let us take a look at its mechanism of action. The exact mechanism of action of vagus nerve stimulation is unknown. What is known is that the vagus nerve is connected to the nucleus of the solitary tract, which has extensive connections to various brainstem nuclei, the thalamus, insula, and the orbitofrontal cortex. Although we do not know which of these connections is fundamental to its effectiveness in the treatment of seizures, it has been shown that the effectiveness of VNS in the maximal electroshock model of epilepsy is nullified by a lesion placed in the locus coeruleus, suggesting that this nucleus is involved in the anti-seizure efficacy of vagus nerve stimulator. Since its initial release, the VNS system had undergone several modifications, including hardware modifications and the introduction of wireless programming in the more recent models. From the initial model onwards, the patient, in case of the occurrence of an aura, or the family members, if they perceive the onset of an event, had the option to activate the VNS manually by the use of a magnet provided with the equipment. One of the most recent developments has been the ability of the VNS to detect and use the patient's heart rate to predict the onset of seizures and to automatically trigger the vagus nerve without human intervention. The patient and family members can still continue to use the magnet to stimulate the VNS as before. Now we will move on to the topic of deep brain stimulation for seizures. Before we move on to the topic, let me talk a little bit about some basic facts about seizures and epilepsy. A seizure is the subjective or objective behavioral manifestation of an abnormal buildup of electrical discharges in the brain, and this is a slightly modified version of Jackson's definition that is over a century old. Approximately 1 in 10 people will have a seizure in their lifetime due to such an aberrant electrical discharge, but it's not considered epilepsy, and only when a person develops recurrent seizures it is considered epilepsy. Only 1 in about 100 people will have recurrent unprovoked seizures, which is what is referred to as epilepsy. Strictly speaking, metabolic disturbances such as electrolyte imbalances, hypoglycemia, and withdrawal states are excluded from the definition of epilepsy. The diagram on the screen is not made to scale. The only purpose of this slide is to indicate that despite the availability of various modalities, the mainstay of treatment for epilepsy still is medications. Let us take a look at how good medical therapy is for seizures. On the screen are the results of data from a landmark study published in New England Journal in 2000. This was a study of first onset seizures, and as you can see, the first drug had a 47% chance of controlling the seizures altogether in the first year. The second drug tried had only 13% chance of improving the outcome, with a dismal 4% chance for the third drug. That left about 36% of patients continuing to have seizures despite 3 or more drug trials. The situation only emphasized the need for newer modalities of treatment. Thus, a group of us led by Dr. Robert Fisher of Stanford met with the Medtronic Corporation at their headquarters in Minneapolis to discuss the feasibility of DBS for epilepsy. The plan was to implant the electrodes in the anterior nucleus of the thalamus bilaterally in our medically intractable patients and those patients who are not candidates for ablative surgical therapy. The availability of Kinetra, which was approved for Parkinson's disease by then, made it possible for us to reduce the OR time and incisions required for implantation and bilateral stimulation of the anterior nucleus of the thalamus on both sides. Thus, the stimulation of the anterior nucleus of the thalamus for epilepsy took shape. With institutional human subjects review board approvals for the study, a multi-center trial was launched by Medtronic for implantation of electrodes bilaterally into the anterior nucleus of the thalamus. After a baseline period of 3 months, the patients were implanted as per protocol and were followed without activation of the IPGs for a month to eliminate any potential bias from a lesional effect related to the implantation. The patients were then divided into 2 groups, with the stimulation applied to one group and not the other. After 3 months of the double-blind phase, all patients were stimulated for another 9 months. It was a worldwide study with 17 sites, the majority being in the USA. There were a total of 110 patients, with the patients' ages ranging from 18 to 65 years. They were on 1 to 4 anti-epileptic drugs at time of enrollment, with an average of 19.5 seizures per month. They had a history of epilepsy for more than 20 years. Close to half had prior venous implantation, and about a fourth had prior epilepsy surgery. 60% of the group had temporal lobe onset, 30% had frontal onset, and 10% had diffuse onset of seizures. These were the results of the study. As you can see from the baseline to the time of implantation, there was a reduction of about 25% in the entire group. Once stimulation started, there was a clear separation between the Sante patients and the control group. Those who received stimulation for the 3-month period had a reduction in their seizures of 40.4% as opposed to 14.5% in the control group at the end of the double-blind control phase of the study. This slide is a histogram of the percent reduction of seizures of 81 patients followed for 2 years after randomization. It's of interest to note that there were 14 patients who remained seizure-free for at least 6 months. The adverse events were as listed on the screen. Almost 30% were device and implantation related and included paresthesias, pain and infection at the site of implantation, and electrodes missing the target. Non-device related adverse events included depression, memory impairment, confusional states, and anxiety. These were seen in more than 5% of the subjects compared to the control group. Depression was already present in 7 of the 8 patients with device-related depression, which resolved in half of them during the period they were followed. Seizure-related injuries were more common in the control group. All memory complaints resolved over time, and none of the patients got worse. Other complications included subclinical hemorrhages noted on imaging studies and infections in 14 patients, 5 of them requiring removal of the electrode. There were 3 SUDEPs, 1 drowning, and 1 suicide. The last of the neurostimulation procedures I will discuss today is responsive neurostimulation, or RNS, for epilepsy. RNS was approved in 2014 and is the first closed-loop stimulation system. It is indicated for use as an adjunctive therapy in reducing the frequency of seizures in individuals 18 years of age and older with partial onset seizures who had undergone diagnostic testing that localized no more than 2 epileptogenic foci. The approval happened earlier than DBS, even though the DBS study was the first one to be launched. This was because even though the FDA panel recommended the approval of DBS in 2008, it took another 10 years for its official approval in the US, but it has been in use in several European countries by then. The procedure requires the localization of seizure foci prior to eligibility for implantation. A craniotomy was required and the device was embedded in a cradle placed in the bone flap that is removed. Up to 2 electrodes are implanted in the previously located foci, and the bone flap with the device is then reattached to the patient's skull as shown in the slide. This is an X-ray image of the device in situ in a patient with 2 subdural strips over the patient's epileptogenic foci, one on the frontotemporal and the other on the frontoparietal regions. The system is particularly suited for patients with 2 epileptogenic zones who are not candidates for ablative surgery, as in this case. The RNS system has been evaluated in 3 clinical trials, including a prospective randomized double-blind sham stimulation controlled pivotal study. The age of patients with temporal lobe epilepsy who received the implant range from 18 to 70 years, and they were taking more than 2 anti-epileptic drugs. The protocol was somewhat similar to that of the Sante study. There was a baseline period after which the eligible patients were implanted and were followed for another 4 weeks with continued collection of data, but no stimulation. The patient stimulation parameters were then optimized in the next 4 weeks. This was followed by a period of 12 weeks of double-blind evaluation wherein one group was stimulated and the other had sham stimulation. At the end of the 20 weeks after implantation, all patients entered the active stimulation phase in the open-label phase of the study that lasted 84 weeks. The responder rate for all patients was 25% at 3 months, increasing to 48 and 58% at the end of 18 and 36 months, respectively. As I mentioned before, RNS is the first closed-loop system in that it senses the onset of a seizure and then in response to it initiates stimulation, thereby aborting the ongoing seizure activity, as you can see from this slide. The specific capabilities of the system include its ability to constantly monitor ongoing electrical activity at the seizure foci, recognition of patient-specific seizure onset patterns, and the ability of programming based on such patient-specific seizure patterns. That concludes my presentation on neurostimulation treatments in neurology. Thank you very much for your attention.